Good afternoon to folks on the East Coast and good morning to folks on the West Coast. My name is Levi Shanks, and I am the Director for Academic and Student Affairs at the Association of Public and Land-Grant Universities. And over the last few weeks, my colleagues and I have had the privilege of assembling this program on mental health for you today. First and foremost, I want to thank all of our guests, panelists, and moderators for taking the time out of their day for such a critical topic, now more than ever in education. We've known that mental health and wellness concerns have been growing on our campuses for decades. And what may have started as traditional collegiate health concerns 30, 40, 50 years ago, like homesickness, imposter syndrome, dating and relationship woes, have been further compounded in recent years, complicated by world events like economic crashes, natural disasters, global warming, war, and of course, epidemics and pandemics. This is no great secret that we sit here today reeling in the aftermath of a horrifying and incomprehensible school shooting yesterday in Texas that followed a racially motivated mass shooting earlier this month in both Buffalo and San Diego, California. The mental and emotional and physical impacts of which are heavy, not just on our students, but also on us as administrators, faculty, staff, and those like me who work to serve them and you. These are difficult and unprecedented times. So, APLU is pleased to organize and host this special event during Mental Health Awareness Month so that its member institutions and others can share stories and insights, learn from one another, and support each other across the public research university and broader higher education community. In fact, just coming together is a valuable starting point for us all. So we convene as we know we need to do more in light of all of these stressors, plus those that I did not mention. And we come together with over 600 of us today, I might add, so that we can serve and support our students in a way that meets their needs as well as ours. As these times are complicated and nuanced, so too must be our response. And so this afternoon, we have assembled colleagues from around the country representing different vantage points of mental health, those in policy, research, advocacy, implementation, and service from both within and external to our public institutions. And those, of course, who work to support students, faculty, and staff at our school. We hope you're able to attend each of our sessions today and similarly hope that they provide you a bit of a respite to be among colleagues talking about such a critical issue. So I say thank you again for coming, and I would like to introduce my colleague, Sarah Barlamay, to introduce our opening speaker. Sarah?
Thank you, Levi. I'm pleased to introduce Carrie Chameleon. Carrie Chameleon is a nationally recognized expert in veteran and mental health policy. She currently oversees both the Veterans Affairs and the Mental Health and Substance Use portfolio for the Domestic Policy Council. Prior to joining the administration, she served as a senior behavioral scientist at the RAND Corporation, where she led studies examining the needs of military service members, veterans, their families, and their caregivers. She has conducted several landmark studies assessing policy options for improving the systems of care that support these populations. She has also led several initiatives related to understanding and improving mental health systems and care delivery. Ms. Tomelian also has specific expertise in suicide prevention, sexual assault prevention and response, mental health integration into primary care, and behavioral health quality improvement. She has testified multiple times in front of both the House and Senate. In 2019, she served as a RAND Congressional Fellow with the House Committee on Veterans Affairs, where she informed evidence-based policymaking designed to reduce veteran suicide. Before joining RAND, she served as Associate Director for Research at the American Psychiatric Association and has authored more than 100 peer-reviewed publications on topics ranging from improving access to and quality of mental health and substance use treatment, improving public health emergency preparedness and response, and improving support systems for veterans, military families, and caregivers. Born in upstate New York, Tomelian graduated from Boston University and received her Master of Arts degree from American University. Please welcome our opening speaker, Carrie Chameleon.
Sarah, thank you so much for that introduction. And Levi, thanks for kicking us off and reminding us of the important reason that we are coming together today, certainly in the wake of some additional tragedies. It is great to be with all of you today. I bring greetings from the President, the First Lady, and the entire White House team as we are working to address the needs of our nation with respect to mental health. I think it goes without saying that our country faces an unprecedented mental health crisis for people of all ages, one which COVID has exacerbated. But in many ways, it predates the current challenges. At present, 2 out of 5 adults report symptoms of anxiety or depression. Children face especially acute challenges as COVID has disrupted routines and relationships. Children are months behind in math and reading, and 1 out of 3 high school students report persistent feelings of sadness. Suicide-related visits to the emergency room are up 50% among adolescent girls, and a majority of parents are concerned about their kids' mental health. And as the Surgeon General underscored in his Youth Mental Health Advisory released last December, the evidence is mounting that social media plays a systemic role in worsening the mental health of countless young people. We know that addressing the mental health needs of students has long been a challenge for institutions of higher education, one that has also been exacerbated by the pandemic. It is during college that many students experience the first onset of chronic mental health and substance use problems, or an exacerbation of pre-existing problems and symptoms that they experienced during adolescence. Last September, 73% of college presidents indicated that mental health of students was a pressing concern on their campus. This is up from 41% just the year before. In a multi-year study, you probably are all tracking that of over 350,000 students from across 300 campuses, researchers found a 135% increase in depression and a 110% increase in anxiety between the years 2013 and 2021. And we know that the pandemic created a large demand for a broad variety of mental health supports for college students, but that the shortage of mental health professionals and burnout across the profession has caused college campuses to struggle to be able to meet the rising need for counseling services. These challenges are why, in his first State of the Union address, the president called for a major transformation in how mental health is understood, perceived, accessed, treated, and integrated in and out of healthcare settings. In March, we released a strategy that is oriented around 3 key objectives. First, we must dramatically expand our workforce and build capacity to meet behavioral health needs for all Americans. Second, we need to connect more people to care by breaking down financial and other barriers. And third, we must foster supportive environments that promote mental wellness and recovery in schools, online, and in our communities, workplaces, prisons, and across the full social safety net. I want to talk a little bit about each of these 3 objectives. First, at the center of our behavioral health challenges is the fact that we do not have enough providers or system capacity to meet needs. 1/3 of Americans live in areas without an adequate number of providers, and our crisis response infrastructure is frayed. We must begin with major new investments in building out our mental health and substance use disorder workforce. This is why the president in his FY23 budget proposed major new investments in programs that will bring new clinicians into these specialties and in programs that will support the development of paraprofessionals and a peer support workforce. We also know that we need to use administrative tools that can support the certification programs for specialists and other types of mental health workers. The president's budget also called for a major transformation in the capacity of our system by building and funding more community behavioral health centers and mental health resources that can respond to people in need. And this summer, we are focused on launching the 988 crisis hotline so that Americans in crisis can call a simple 3-digit number and be connected to someone who can respond. We're building out this critical infrastructure so that when people need the help, they will have it available. Now I want to talk about our pillar to expand access and connect more people to care. Unfortunately, less than half of Americans with mental health needs receive treatment. Costs and stigma are often a barrier, and care can be inconvenient or confusing to access. So our strategy takes a comprehensive approach to break down these barriers. We're focused on trying to strengthen laws that already exist requiring health plans to require mental health and substance use services to be covered at parity with physical health services. This standard is too often ignored, and the administration is focused on taking important steps to enforce the law as well as to strengthen it. The President is also calling upon Congress to modernize the requirements so that all insurance plans are required to cover robust behavioral health services and to provide an adequate network of providers and expand additional tools to help enforce these standards and hold health plans accountable. We know we need to do more to expand access to telehealth and facilitate the appropriate delivery of telehealth across state lines, an issue that I know is very, very important to institutions of higher education. We need to meet people where they are by integrating care into new settings, including schools and college campuses. The President's budget calls for new investments in mental health resources in schools, and we're taking steps to make it easier for schools to be able to access Medicaid funding for services delivered on campus. We also are asking the departments to build easy to access, user-friendly online treatment locator tools, starting with a redesigned and refurbished mentalhealth.gov. The third element of our strategy is really rooted in an understanding that no health problem can be addressed by a healthcare system alone. We know we need to address the determinants of health in our environments. That's why we're calling for action around social media's mental health harms, especially for young people. Just last week, we announced a new funding opportunity for a new Center of Excellence on social media and mental wellness. We hope that this will help develop and disseminate best practices so that we can protect kids and young people online. We also need better support from the youngest brains throughout the lifespan. We need to make sure that we can encourage folks to be able to get the services and support they need across the continuum. Our strategy is also focused on helping people navigate difficult transitions, particularly for young adults, and working to make the social safety net ensure that it has got the right training for detecting and connecting people with mental health problems to the services they need. We know that mental health is an issue that touches all Americans, and your role as leaders in institutions of higher education is critical to helping us achieve the President's vision. We hope that you're already leveraging resources made available through the Higher Education and Emergency Relief Fund to meet the mental health and substance use needs of your students. This one-time infusion of funds from the Department of Education is really helping to invest in the mental health support for college students now. And institutions may be eligible for other sources of federal funding, so we encourage you to keep an eye out for other opportunities through the Department of Health and Human Services. Again, I just really want to thank you for your leadership, your commitment to addressing the needs of your students and your fellow school leaders, and know that this is a priority for the President as well as Dr. Biden. It is personal, and we look forward to continuing to work with you. So Levi, I'm going to turn it back over to you. Thank you.
Hi again, and thank you so much for sharing how the White House is thinking about mental health challenges facing our country and the steps the administration is taking to help those in need. One question on the minds of many college campuses is, what more can we do to partner with the administration in this work? Do you have any recommendations for where campus leaders can start to engage?
Yeah, thank you so much for that. And, first I would point you all to the Department of Education and the resources that we have made available through the American Rescue Plan, but also some of the resources that have been published. But we also invite your outreach directly in terms of what you're seeing and hearing on your college campuses and any innovative solutions that you've been able to develop. We're focused on trying to break down some of the systemic policy challenges that we know exist to try to make it easier for individuals to get the services they need, and also to kind of spur opportunities of innovation and wellness and recovery so that we can prevent mental health problems from occurring, but making sure that we have the resources to respond when they do. So we look forward to being able to be a partner and again, working collaboratively to address the needs of young people.
Wonderful. And we know that those resources are drastically needed on our campuses. So we're glad to know that the administration is supportive of that. Next question is, during the pandemic, we've seen increased attention to the potential of telehealth solutions in meeting the needs of students, particularly for campuses and students that may be in areas with very few providers available. Moving forward, do you see any new pathways for expanding access to telehealth or allowing mental health providers to provide telehealth services more nationally rather than just within their states?
Yeah, absolutely. I mean, so I think one of the silver linings of the pandemic was seeing the hope and opportunity, as well as the safe and effective use of telehealth for the delivery of mental health and substance use services in particular. And so HHS last week just announced a new effort. They'll be doing launching a technical expert panel, as well as some other activities, so that we can devise a federal framework that might inform how we can promote greater license reciprocity and portability, so that we can move towards more voluntary compact opportunities to be able to facilitate the practice of telehealth across state lines. For some professions within the mental health community, there are existing compacts, although they're not everywhere where we know we need them to be. And in other professions, they are yet to exist. And so we're really focused on trying to leverage opportunities to expand these voluntary interstate compacts, while we also look to our colleagues in Congress to consider additional opportunities to expand access to telehealth across state lines. And for some of the professions where there is and are national licensing and certification opportunities, to kind of work to see how we can ensure access, again, across those boundaries. We know it's critically important. I can say when my own children were in college, the important opportunity that they had to be able to maintain relationships with their providers while they were either at school or at home was really critically important. So we want to make sure that we can continue to afford those opportunities. So we're working on what we can do administratively through the Department of Health and Human Services, and more to come on that before the end of this calendar year. We hope to achieve some success. But also looking to our colleagues on the Hill to see what can be done legislatively.
Of course, of course. Well, thank you for sharing that. And one last question that I have that we're going to be hopefully asking all the rest of our speakers throughout the remainder of our scheduled time today deals a little bit with data and with your hope for the future. So the question is, a lot of data we're seeing right now presents a fairly stark picture of the state of American mental health, both on colleges and throughout. So in working on this issue, are there any bright spots or areas that sort of give you hope for the future?
I will say, I think one of the bright spots is the willingness of young people in particular to talk about the issues and challenges that they're facing with respect to their own mental health and substance use. And so where I see hope is in those young voices and their leadership. Last week, we had the privilege of the First Lady hosting a conversation on youth mental health here at the White House, and listening to the examples and the stories of those young leaders was truly inspiring. And so I'm reminded that our young people are taking action and working to promote their own mental health, but in doing so, also trying to lift up and address the needs of their peers and in their community. And so I think as we are willing to talk about it and to address it and promote help seeking, we are working to dispel myths, change attitudes and biases, and begin to kind of really address the stigma and the stigmatization and true discrimination that has occurred for far too long when it comes to individuals struggling with mental health and substance use challenges. So I'm hoping that our willingness to be having conversations and putting mental health front and center will help us finally realize that mental health is health. And we need to do more to ensure that people can gain access to the services and supports that they need to stay healthy.
Wonderful. Well, that concludes my questions. Thank you so much for spending your Wednesday afternoon or a couple minutes coming to speak with us and kicking us off. and for everything that you said with regards to the commitment from the administration, your personal work, and your highlighting the bright spots of the young folks, which we all have the opportunity to work with in some capacity. I know that you can't see everybody here, but I want to extend a heartfelt thank you from all of them and all of us at APLU. Thank you for your time.
Thank you all, and good luck with the rest of the symposium today.
Of course. To all of the attendees, I want to thank you all for coming. We've got a few minutes between Terry Chameleon speaking and our very first panel. So in the lead up, while we wait to get all of those folks onboarded and ready to go for our panel, I wanted to advise everyone that the next panel is going to be titled Data, Advocacy, and the Interventions in Student Mental Health. And what we'll be talking about with that group is focusing on individuals who are working in mental health, both within and outside the institution, to give a little bit of vantage point on how this looks from their perspective, both immersed within data or within advocacy, or in doing some third party or external assistance with institutions. So we invite you to stick around, and we will be reconvening at 2:35 Eastern Time. Thank you.
All right, thank you everyone for returning. We're about to begin panel one for our time this afternoon. Briefly before we went to the intermission, Levi introduced the second panel, which is the topic Data, Advocacy, and Interventions in Student Mental Health. And I am pleased to introduce the moderator of our first panel. Dr. Mary Krogen has been with the American College Health Association for 25 years and currently serves as the Chief Research Officer. Mary holds a PhD in Public and Community Health from the University of Maryland, College Park, and is a Master Certified Health Education Specialist. In 1997, she left the University of Maryland University Health Center to manage a 10-year, $2.5 million CDC-funded HIV prevention project at ACHA. Mary and her team have primary responsibility for administering the American College Health Association National College Health Assessment and all other survey efforts at ACHA. Please welcome the moderator of our first panel, Dr. Mary Krogen.
Thank you, Sarah. I'm pleased to be with you guys this afternoon representing the American College Health Association and getting the opportunity to engage with this impressive set of panelists that we have to learn from this afternoon. I look forward to learning with you. You'll meet them in just a moment. Across the country, colleges and universities are facing huge challenges. Increases in the number of students reporting depression and anxiety, suicide ideation, and at the same time, our college health centers and counseling centers are reporting decrease in staff and difficulty keeping up with the demand for services. Given the alarming data that we have in the area, we want to turn to think about how we can leverage some of that data for both positive and sustainable change on our college campuses. This afternoon, we've pulled together a collection of researchers, scholars, and advocates to discuss their views of mental health on college campus. I'm going to ask each to introduce themselves individually, and then we'll move into our questions. I'd also mention that we've saved plenty of time towards the end of the session to hear your comments, questions, and thoughts as it applies to the topic. So please be sure to use the chat box to submit those questions. First, I'm going to turn it over to Dr. Daniel Eisenberg.
Hi, everyone. I'm sorry about the ambulances in the background. I'm at UCLA campus. I'm right by the health center. I'm in the School of Public Health at UCLA. I'm a professor in health policy and management, and my research team has been running the Healthy Mind survey study of college student mental health since 2005. I was at Michigan for a long time before UCLA. It's great to be here.
Hello, everyone. Can you hear me? Great. Sorry, my audio cut out, but my name is Ethan Fields. I am the Director of Higher Education Program Outreach and Promotion here at the JED Foundation. We are a nonprofit focused on protecting the emotional health and preventing suicide for our nation's teens and young adults. And we partner with college universities, including over 70 members of APLU in our signature JED Campus program, which helps campuses create a strategic plan to address mental health, substance misuse, and suicide prevention. My background prior to joining JED is in student affairs, working on college campuses, mostly in residence life, student conduct, and integrating restorative practices. So very excited to be here today.
And good afternoon, everyone. I am Zainab Okolo. I am a strategy officer for student success with the Lumina Foundation. I lead a body of work that focuses on adult learners of color and another that focuses on student mental health. Lumina Foundation focuses on making sure opportunities for learning beyond high school is equitable and accessible to all. And as we envision a more accessible and integrated higher ed landscape, we also look at barriers and opportunities towards that success, including mental health. So happy to offer my expertise and background, and looking forward to learning along with you all today.
Dr. Hoban, I think we lost your mic. We can't hear you there.
I'm sorry, how about now?
Much better.
It's unfortunate because that was the most profound thing I was going to say this afternoon. Let's dive right in to our first question. From each of the panelists, what would you say are some of the field level observations about the current efforts to support mental health in higher education?
I can begin. I think, the working at JED, we have the privilege of working with over 400 campuses nationwide, and well over 1,000 campuses use our resources every day. And what I'm seeing from our data and from our day-to-day interactions with campuses is that we are seeing an increase in campuses investing in mental health resources for their campus, whether that could be increasing the staffing in their counseling centers or adding maybe a third-party telehealth option for their students. However, even though most campus presidents or upper administrators would say that they're prioritizing student mental health, many do not have a comprehensive strategic plan or task force that sits at a high level that is continuously addressing community mental health and well-being. And so many of the actions are happening in pockets across campus, and there's not a centralized, data-driven or evidence-based approach to addressing these issues systemically. Another thing I've been seeing is that through our work with systems of higher education, since many public universities are part of higher education systems, is that even though individual campuses may be doing their part to address these issues, there are systemic barriers to addressing equity in mental health and well-being across an entire system of higher education. JED has the privilege of working with the entire university system of Georgia, the Utah system of higher education, and the Connecticut State colleges and universities. And through that work, we've been able to address major policies such as medical leaves of absence or health insurance, or looking to ensure that there are equitable services placed on each campus related to mental health, and looking at that not just from an individual campus perspective, but looking at it from that higher level has made a world of a difference. And then I would say another thing is that looking at all the spheres of control, so again, on our individual campus communities from a system or state level, there's also outside influence that's occurring around laws that may be passed at the state or federal level. So for example, in Connecticut, a recent law was passed that's requiring campuses to create a task force around mental health and well-being to address any potential shortcomings they have with their services, to create centralized policies. So you're seeing also in New Jersey, a law that may be passed here soon that's requiring campuses to take more steps towards reducing access to potentially lethal means on campus. They're doing environmental scanning. So you're seeing all these different influences coming together because of everything that's happened in the past 2 years around COVID-19 pandemic, the results of continued systemic racism and gun violence in our country, that for our students, mental health and well-being is top of mind.
So just to add to that, although Ethan is a very tough act to follow with all of those very helpful insights, I think that the one field observation that I will make from my perspective, working from a philanthropy, is just noticing right now what we're actually witnessing with institutions. And as you mentioned in the framing of this conversation, Dr. Hoban, this is an exacerbated issue, and it almost resembles the awakening of a sleeping giant. The demand for mental health resources on campuses is a 15-year-old cry out. And what happened with the pandemic, what happened with the current civil unrest, what's happening with our current mass shootings is now students are saying, if I don't feel psychologically safe enough to engage with your institutions, I just simply won't attend. And we are now having to have serious conversations around looking at our enrollment, what we're willing to provide for students. And so institutions are doing their best to put into place programs, partnerships, further investments into ensuring that students simply feel psychologically safe enough to participate in pursuing their degrees. And as we're looking at the data to find out what our evidence-based practices are, we have to be humble enough to say, we're not 100% sure yet. What we're seeing are promising practices. We see what students are responding to. We are seeing what systems are able to quickly assume. But the challenge now is about bringing some of those opportunities to scale and ensuring that the outcomes are what we want them to be, which is students being able to go on campus, pursue their degree, feel safe enough to do so, and also leave with a quality credential at the end of their time at college. And so I think we have a couple of things going on at the same time. And it probably feels like we're drinking from a fire hose, because that's exactly what we're doing right now.
I'll just add from a kind of the data point of view with our survey, our Healthy Minds survey study, and also Dr. Hopen's National College Health Assessment. I think we're seeing quite clearly as you all know, an increase in distress that college students are reporting, and it's a massive increase. It's approximately a doubling of students who appear to meet criteria for depression or anxiety disorders today versus even before the pandemic compared to 10 years before. I think that's a combination of, it's hard to tell, but I think it's a combination of young people are now more willing and able to recognize some of the symptoms and report them on a survey like ours. But I think it also reflects a true increase in distress. And there's lots of theories about why that might be. Digital and social media probably is playing some role in this, but there's other things going on related to digital and social media. I think sleep health is often underlooked. So there's a big challenge there, and you all are seeing on your campuses that it's resulting in ever increasing demand for services. But at the same time, I think there's this opportunity, which my co-panelists have alluded to. There's some good things going on. One of them is the increased willingness to seek help and the kind of the increased general knowledge and energy around mental health that students and young people have these days. And we see that in the form of student advocacy groups, organizations like Active Minds, and all kinds of other efforts around the country that involve students themselves. So I think there's an opportunity to address this growing challenge, but it's it's a mixed picture right now.
Dr. Hoven, I think we lost your mic again.
How about now? Well, I see my box is lit up. Thank you. I'm going to take my hand away from that button. It's not working for me. Thank you, everyone. Made some really important points. This is clearly not a new problem that we're trying to address. It's one that's been growing and coming to a head for quite some time, and the pandemic just sort of shed all the covers off of some of those problems and concerns on campus have made them an even greater challenge to deal with. So kind of moving into some of the work that you're doing, what would types of mental health support do you believe need more attention from our campus administrators? Mix it up a little bit.
I'm happy to start this off,
Great.
Dr. Hoven. I think, and I think Ethan and Dr. Eisenberg already alluded to this, but there needs to be a true commitment to culturally responsive modalities, especially as we are acknowledging and taking on the fact that we are all collectively going through and processing a complex trauma. Just to kind of give some defining background, my background is as a marriage and family therapist. I've been a licensed clinician for 13 years, and I'm a trauma-informed therapist. And there are three types of traumas that really come into play that have grave impact on the way folks learn and live and work. That's acute, chronic, and complex. Complex is when you are exposed to varied and multiple traumatic events, so much so that they become invasive and almost impersonal. So you feel yourself numb, or you don't know how to react to that. But just because you're numb and you don't have a direct reaction does not mean that you are psychosomatically not being impacted and reacting. And so with that, although there's been hesitancy and not enough work being done around how to call in resources for Black and Brown students who oftentimes need the most supports, especially in times like having a pandemic and being more likely to be frontline workers and being less likely to have access to resources, psychological assessments and supports, it's time to ensure that when we think about resources on campus, that we do so from a place that is culturally responsive, that we have a diverse array of practitioners on campus. And in terms of the demand for that, also opening up our campus doors to make sure that we engage with practitioners right outside of our campuses. So creating partnerships with practitioners, with the inpatient, outpatient clinics right in the proximity of your institutions would be something that could probably bring us along in terms of meeting the demand.
Thank you. Anybody else want to add to that?
The first one on my list was culturally responsive care. So to expand on that, I also think about trauma-informed care, and that those practices aren't just meant for those that provide mental health services, support services, but that we infuse those tenets across our entire college or university, that our faculty understand how to integrate practices into their classrooms that can build a culture of caring. I think in expanding upon that, as we're looking at, the increased demands related to mental health on our campuses, that therapy should not always be the default. When we're thinking about a student's care, sometimes they just need someone to listen and to be there with them. And so we always say at JED, there should be no wrong door on campus for a student to get support. And so when we build a strategic plan around mental health, we're looking at all those different touch points for a student, that for many students, the people they may interact with most on a daily basis are the dining service workers or a custodian in the residence hall, or maybe they have moved to a rural campus from an urban area. And even though their campus community may be welcoming, the outside community may not be. So we have to think about it from an equitable implementation standpoint. We have to understand what our students' lived experiences are. And the way to do that is making sure that they are central to the work that we are doing. If we are convening a task force to address this issue, we need to have student representation on that. So as Dr. Eisenberg was mentioning Active Minds, there's often chapters on campuses or other related groups. Within that, builds a layer of peer support, as we know that students are more likely to go to a peer or a family member before they would ever come to a faculty, staff, or counselor. So how do we infuse peer support, peer education, peer mentorship across our campus, and that those peers are trained in culturally responsive and trauma-informed practices that they're reasonably able to provide to one another? And I would say another, when we're talking about, the mental health supports that we believe deserve more attention, I think that mental health training, so those for folks to recognize warning signs, to intervene and respond effectively and make a referral if needed, needs to be at the same level as Title IX. Anti-harassment training, data security. Oftentimes, those are offered on a volunteer basis, not as a requirement. And a campus should think about those trainings on a spectrum based on the different populations. And I would say the last thing on this topic, would be to think about the root causes of some of what our students' experiences are, which come down to academic related stress and stress outside in their work life, balancing everything that they may be doing. And so we have to look at our academic policies and our academic systems and recognize that the students that we have today are not finding success in the systems that we've had in the past. And so we have to be courageous and be brave to address those issues.
Daniel, do you have anything to add to that?
I just fully support what my co-panelists just said, and just maybe to build a little bit off of Ethan's answer. I think what he's conveying and what we've tried to convey through our work is a public health approach to mental health, a very holistic approach where it's not just about mental health care. It's not just about therapy, counseling, and medication. It's about creating a supportive, nurturing environment in every dimension in a campus, whether it's related to students' identity, whether it's academic, financial, residential life, and so on. So I just wanted to highlight that key point.
Thank you. Good points. Let me ask what insights you guys might be able to offer professionals in higher ed to further support faculty and staff mental health, maybe the role that might play in student mental health. Curious about your thoughts around that.
Maybe I'll just mention that with our Healthy Mind survey has a faculty and staff version. So we are trying to collect data just to get a sense of how our faculty and staff doing in terms of mental health and what kind of experiences are they having, and also how are they interacting with students with respect to mental health. Are they talking to students? Are they comfortable? Do they feel equipped? So stay tuned for data on that front, but we're already seeing, as you might expect, that faculty and staff experience mental health challenges just like students do. Maybe not quite at the same prevalence rate, but not far off. That's the thing about mental health, is that it's relevant to every population, every type of person, every community. So clearly, this should be a priority for institutions, just like K through 12 schools have come to realize that social and emotional learning for their students can only take place if the teachers and other educators are actually on board and are actually they themselves have these kinds of skills and support.
And if I could just add to that great point, I think that the framing around this current mental health crisis as a public health call out and cry out is going to be significant, because I've in the process of a listening tour and discovering who to best partner with and what types of evidence-based practices are happening on campuses, I've really heard the frustration of faculty and staff as we are equipping them to best serve students, them crying out and saying, we went through the same pandemic and we're not exactly okay, except we don't have necessarily a system that's asking us and checking in with us. And that's why it's going to be so important that as we lift up this work, as we begin to decide which programs, which opportunities need to be brought to scale, that we remember that this is going to require a cultural shift. Not too long ago, talking about going to a therapist or involving yourself with mental health was a bit of a taboo. Folks were not exactly sharing that publicly. That wasn't something that was conversational. And so with that, we still have a couple more steps now. And we do have some institutions that are further along than others, but all are now more willing to address this as a public health issue. And so with that, there needs to be some flexibility, some grace also afforded to faculty and staff, that as they're being trained on how best to address students, as they're being trained on how best to be able to witness and respond to red flags on campus, that they too are given an opportunity to kind of take their own pulse, that they too are made aware of what resources are available to them, so that they from a healthy place can pour out and help other students and reach out. But if they themselves have not had a chance to take a beat to process the trauma that they've gone through, we are asking them something that is way more tasking than I think that we're giving it credit for. And so I think this is conversations like these and the ones that we'll get a chance to have now in the wake of expanded funding around HERF funding towards mental health, for example, I think will allow us to become a little bit more creative and a lot more inclusive on who we mean by campus mental health and who actually needs resources and access to those resources.
Thank you. Yeah, we can't address students' mental health in a vacuum without considering the entire environment. And I'm glad you mentioned the HERF dollars. They specifically call out students, faculty, and staff, and which is an enormous step in the right direction. It's nice to see the federal government recognizing that. I'm wondering if we can talk a little bit about, since the HERF discussion came up, if you guys had a wish list, for the opportunity to spend some additional money on campus mental health, and God knows it's not going to be nearly enough. What are some of the things you might look to first to invest in, would you say?
That's a great question. I saw someone put in the chat, I think when we were talking about peer support, about paying peers. And so where I want to go with that is that to create prevention programs and removing the barriers for students to actually access and participate in those programs. So oftentimes students aren't able to be a certified peer educator or to go through the training to be a peer support person because they have to spend their extra time working a job to be able to support their education. So finding ways to utilize that fund to create a sustainable program that will go beyond the HERF funding, and that will become part of again, like a line item in your budgeting, that will really address, again, a culture of support. Of course, there are lots of options out there in terms of thinking about third-party services, but oftentimes that's not a sustainable way to address this issue, because if you lose that funding, you may not be able to make that back up, and then with that you will lose a point of access for services. So I think investing in evidence-based programs that we know work, trainings that, again, that faculty, staff, and students can take to be able to better support themselves and others, that we're investing in that peer level support, and that we're using tools like Dr. Eisenberg was saying around like the Healthy Mind Study faculty staff survey. That could be a great way to get a baseline of what your faculty and staff are experiencing, what their knowledge levels are, to inform your strategies, as well as collecting valuable data for your students, like through the ACHA survey, a Healthy Mind survey, etc.
I think one need for a lot of campuses is helping students just make sense of the resources available to them. It's like a place, I understand that many campuses maybe don't yet have enough resources, but at the same time, I think there's a problem that there's so many different options for students now that there's all these digital tools and also a lot of in-person kind of resources, peer resources, counseling centers, psychiatric services, and so on. And it's not always clear kind of where to start, and that can be a barrier in itself. So I think kind of navigate. One potential solution is navigators of some kind, of people who are easily available to help kind of students figure out, and perhaps those could be peers that could be trained. Also, of course, online versions of that where students could maybe take a brief screen about what they're experiencing, what their needs are, what their interests are. And then there's a very clear kind of guidance about, well, here are some things that are available to you, and here's how you could learn more about them or try them. I understand that schools are already doing some form of this, like through their counseling website or other places, but I think we still need a lot of progress in that domain. So I would say invest in something like that, but then also evaluate it rigorously and carefully and share your results, because there's a lot of learning to be done that can be shared with the rest of the community nationwide.
My colleagues made a lot of good points that I would have totally made as well. But to add to the wish list, I want to take the time to consider that when looking at traditional age students coming to college, institutions are inheriting large populations of students with undiagnosed mental health challenges. This is known in the mental health world as late onset. So anytime a student or a person is diagnosed after the age of 15, that's considered late onset. And oftentimes looking at mental health in parity with physical health, this is where we get into urgent care versus preventative care. If we knew earlier, we'd equip them with the right IEP, with the right screening, with the right medication, perhaps with the right supports. And sometimes when students, particularly from Black and Brown backgrounds that don't have access to those kinds of resources, they come onto campus and they're not only learning how to adapt to college culture, they're learning how to adapt to themselves. This is their first time away from what they've known, their comfort zones, their family systems, and you get introduced to yourself in a new way when you're embarking on your new independence. So I think my first thing on my wish list, in addition to all the things that were mentioned, would be access to opt-out screenings. And so institutions, of course, we have programs where students would have to opt out. So unless you opt out of receiving this free psychological screening, this individualized education plan just for you, then this is what's coming as part of your package, so that we know that you not only have the classes that you need to be successful, but you have ways in which you can be successful. And I already know that that's going to, I can almost hear the screams. It's very, very expensive. It's an expensive process, yes, but it's a worthy process, and it shouldn't be priced out for students that actually need it. And so thinking about ways to have longevity around not only addressing the need, but also addressing the need to destigmatize mental health, we're going to have to ingrain it into the way we operate, into the way we make our services available to our consumer, our student. And that could be one of those ways.
Thank you. Clearly that we're talking about access to care, access to culturally appropriate responsive care, as well as all of these things that impact the environment, building a culture where you know how to find help and it's okay to ask for it. We have a lot of work to do, but I appreciate your thoughts there. Before we move into the questions from the audience, I want to pose one last question to our panelists and ask you to think for a moment about what are some of the short-term and long-term predictions you have about what institutions should be on the lookout for on campus with regard to mental health. Get your crystal balls out and let us know what you think.
I guess I can begin. I think that what Dr. Eisenberg said, like with the data, we know that we've been seeing this trend increasing year upon year, whether it is more students screening positive for depression or anxiety, or coming to us, like Dr. Okolo said, with lived experience or it showing up by the time they come to college. But we also know that additional symptoms and stressors are continuing to increase, like social anxiety in particular has been showing up more, mostly as a result from the pandemic. And so I believe that as we're thinking about this, it goes back to my very early point in this panel discussion, is that you have to convene a task force related to this. And I think it's going to become more of a norm on campuses to create this kind of healthy campus health and well-being initiative that brings together faculty, staff, and student well-being. and that we recognize that these efforts cannot be the responsibility of just our wellness centers or student affairs or human resources to be able to address this. But as a community, we must have the right folks together in that space to work on this, and that we need to leverage our community connections to be able to think about our students, not only as students on our campus, but as residents of that local community, and how we can advocate together for the needs in our communities, as we know that many campuses are struggling to hire counselors, and now they have positions open, but they're not able to have a competitive salary. I was at a breakfast last week with university presidents in Pittsburgh, and one president said, "How am I supposed to compete with Target that's paying $24 an hour when I'm trying to hire a therapist?" Which just blew my mind, but was such a candid way of pointing that. And of course, that's on all of us to take that collective action. And by having data to inform this work, by talking about this need, by convening this group and creating a community-wide action from the top down and bottom up, hopefully we can move these things forward. But I think the key is that that no matter what, we have to have a strategic plan to be able to address it. And it needs to be long-term, ongoing, not just a short-term fix for this.
Maybe this may be more of a hope than a prediction, but I'm optimistic, so I guess it's also a prediction that I think mental health will increasingly be regarded as intertwined with the central mission of institutions and in higher education. And I don't mean mental health care, because clearly there's a broader mental health care system that has all kinds of issues and that needs to be strengthened and transformed. What I really mean is more kind of a holistic view of mental health as being integrated, as we were talking about, with academic success, with diversity, equity, and inclusion, with substance use, with all the issues that are important for students. So I think increasingly institutions will think of themselves as having an important role in promoting mental health of students, because that furthers all other aspects of the mission, the educational mission, the mission to help young people develop, or people of any age to develop and be successful in their careers and later in life. Mental health is fundamental to that. And so I think institutions will increasingly be finding effective ways to promote mental health through a more supportive environment in all aspects of campus life.
And not to follow up with a pessimistic view, so I'll try to frame what I'm going to say appropriately, but I do think that we are in a unique moment that we are doing our best, my colleagues and I here, to really lean into. What I know about trauma is that it has a long tail. So there is an impact, there's a hit, then there's a reaction, but there's a longer reaction that impacts behavioral, emotional, cognitive, interpersonal, somatic outcomes. And what we're seeing right now is just the first round of impact from a few things that we've seen recently. Some of the things that we're experiencing, we have not fully processed. Our system has not fully appreciated or processed, because that's what happens when you're going through a complex trauma. Things are happening back to back to back. So I do want institutions to prepare, not to be afraid, not to feel like there's no hope. Gratefully, we have amazing advocacy organizations like the JED Foundation, like CFUN, that are on the ground doing work to create frameworks for institutions so that you have tools. The Department of Education and other state level systems as well are thinking about ways to bring some of these operationalized evidence-based practices to scale. But I think that as we go along, what happens in response to trauma are things called change back signals, where we're hoping that if we just look away long enough and we act like things are normal, things will go back to normal. This is not that time. That can't occur. And we have a generation of students now. I'm thinking about the tragedy that I think we're also processing from yesterday. think about this, where we're dealing with 4th and 5th graders that we will inherit into our systems in just under 10 years, 7-8 years. And at their formative years, at the formation of their frontal lobes, they're experiencing this trauma. And even if you're not in Texas, I'm thinking about the students outside in other states thinking to themselves, are they safe enough? Are we exempt? Are we safe? And they bring all of that with them into their educational experiences. Now what institutions are having to do is think about what these students need, what they need immediately and what they need in the long term. And to do that, I think what's going to be an optimistic point of view is that we have a longer table now. I think institutions, I think higher ed as a space is willing to have a larger conversation with other practitioners outside of our ivory tower to think about how best we can address the need and how best we can strategize around what students need and how best to implement the next steps in terms of solving for the issue.
Thank you. I don't know if each of our panelists has the ability to kind of read the comments as they're coming. I can't do two things at the same time, so I've been looking while you guys are talking. And it's clear the audience is really resonating with the points that you're raising. And I think if we were in person, you'd be hearing some applause and amens. So as we switch to some of the questions from the audience, my first one here is for Daniel. Curious as to what leading indicators you might suggest that think about to make sure we are proactively addressing this important issue. Many of the ones that we tend to monitor are lagging indicators. It's a good question.
Yeah. And I think also not only that, but a lot of the measures that we think of first in terms of mental health are not really under a campus's direct control, or I should say, reflect so much more than just what campuses are able to do. Like for example, the percent of your students who are experiencing depression, that we want to lower that for sure, but that to actually change that involves campus efforts, but so much more in our society. But I think something that's maybe more kind of malleable, more modifiable from a campus point of view. And actually, Ethan could probably speak to this because the JED campus program is really all about like, let's focus on some indicators that we can change in the next few years. And as one example, in our survey, we asked students about the climate in various dimensions, like how supportive do you feel like your college or university is with respect to mental health? Or also like how supportive do you feel like faculty are, advisors are with respect to mental health or respect to students of different identities? So those are the kind of climate things which I think we can make a difference and we can see some progress. And so those, I could point to those as kind of indicators that we're going in the right direction. Also, things along the lines of actually students feeling like they have a good sense of what services to use, that they feel like services are available, that they're actually using services. Again, those are not the end all be all outcomes, but I think they're more feasible to change in kind of the shorter term.
I would add, if I could, I think some of the measures too around resiliency and the flourishing, some of the other things that we're measuring, learning more about those kind of precursors before we're actually measuring diagnosis of depression or suicide attempt can be very helpful as well. Our next question is, for Dr. Okolo, what you're talking about this opt-out screening program, and there's some interest around this, and they're looking for kind of an expansion on that. If you can talk a little bit about what kinds of things do you think students should be screened for, and should the results be shared or not shared with the school, like all the rest that comes with that, we're kind of curious about.
Oh, Well, that's a great question. My colleagues are giggling because they know that that was on my wish list, so it doesn't exist. So I will walk you through my dream. When I think about opt-out screenings, so first of all, opt-out, I mean by programs, almost like orientation. Every student that goes to a college campus must participate in orientation. You do not get a choice as to whether or not you are oriented. You also don't get a choice as to whether or not you take University 101. That is kind of built into your curriculum. And what would it mean as we think about shifting campus culture to integrate mental health awareness, mental health education into a student's learning arc, as they're learning how to assimilate to campus, get used to their independence at the very beginning of their experience. And so for me, this would be the creation of a quick assessment to assess students for what they're most likely to find out that they are challenged or diagnosed with. Between the ages of 17 and 22, on average, students are more likely to be diagnosed with anxiety, depression, bipolar, and OS. That means not otherwise specified, meaning they might not have a family background with bipolarism, but when it strikes, they're having manic episodes, their sleep is completely off, sleep health is gone, and they're not able to show up. And if they are having a manic episode, they have all the energy in the world, they might be doing well for a while, and then they crash. When these things go undiagnosed and students don't know what's going on internally, they then lend themselves to coping behaviors that are equally just as dangerous and unhealthy. Unfortunately, we have a culture that has romanticized some of these coping behaviors: college drinking, over partying. Mind you, I said over because I think there's a balance in everything. Risky sexual behaviors, overspending, and we call that coming of age. No, it's not. Oftentimes it is coping in response to things that students are experiencing that they don't have the words for and don't have the resources to reach out to. And oh my, if they have other peers that are going through something similar and they've now normalized it amongst themselves. So what would happen if we took a beat to let students know, hey, as you're getting to know this institution, we recognize that you're in a life stage where you're actually getting to know yourself as well, assess for it. And if we find something on your indicator, you are partnered, you are onboarded with a therapist, you are brought into a student therapy group, something that would allow you to know that you have those supports and that you already have that culture built in. So that's what I was thinking through in terms of opt-out assessments and resources.
I was just going to add to that. We, when we're working with campuses, we do look at screening similar to what you're saying about the entire life cycle of the student. Of course, there's no perfect system out there, but from point of admittance through health history forms and creating automatic messaging that aids in that transition of care between high school and college, as well as infusing screenings into unique ways. So one campus that I work with actually included as part of their 6-week check-in for their new students. They added in some of the simple screening tools that we know, and that allowed them to have that conversation. And it was kind of that opt-out model. They didn't want to take it, they didn't have to, but most students would because they want to talk about their mental health. And that was the first time they felt like, oh, somebody's actually asking me. And so that academic advisor was able to have a caring conversation and refer if needed. So great.
And Dr. Hoban, can I just add one more thing? Only because I see in the chat somebody mentioned, this is a great idea, but what if it's too invasive? I totally agree with that. But to Ethan's point, I think that would be the benefit of having something like opt-out, because having had a background in student services, most students entering into college with FERPA laws that protect them from privacy from at least their parents won't know, so they have enough privacy to kind of explore themselves, actually would probably not opt out. But if in the process of us shifting our culture, I believe that we would find more and more students taking advantage of these resources. And so it's not something that they would that would be snuck on them, that they would be forced into, but it would be a resource. And so even for the students that decide not to engage, they would have an opportunity again, the beginning of their sophomore year, midway through, something that would allow them to know that no matter what stage you are in your academic walk here, if at any point you need resources, you have them. Remember, this is a program that we introduced to you your freshman year. This is how you build out conversation. This is how you build out culture. This is how you put it into the water of a campus so that it is so normalized that by the time students are looking out for help, several folks on campus are able to point them to resources, not just the high touch practitioners like an academic advisor. This is when other folks on campus know that they're able to signal for students, hey, have you taken advantage of your, I'll think of a cool name, your mental health framework assessment, something that would be part of the language that would allow students to feel empowered by their self-discovery. And some of this has to be around framing and reframing. And I think Jet Foundation does a fantastic job of doing that with empowering language that's not disempowering, that doesn't make students feel outed or othered, but instead empowers them to get to know the resources that they need to be their most successful selves.
Great, thank you. How about, can we talk a minute about telehealth and the role of telehealth in mental health services on campus and what we've learned about its efficacy, sort of your thoughts on the future of telehealth?
And if we can expand that, maybe also not just to telehealth, which is like providing therapy virtually, but also like self-guided. There's all kinds of other digital options like self-guided therapy, and then like mindfulness apps and so on. I think there's a whole range of options that are now available. And I think the biggest challenge, as many of you know, is simply engaging students in it, or anybody. It's a in-person therapy already. There's a challenge to actually get somebody to come in and then to come back consistently. But it's just even more so when it's so easy to attend, but it's also so easy to skip and so easy to stop. So, but I think college campuses have a unique position where there's this whole rich in-person network at most campuses that could actually reinforce and introduce and sustain the use of virtual tools, whether it's teletherapy or other. So I think we need to think about that intersection of the in-person community and the virtual support.
Now, I think one thing that came up in the pandemic is that when we all had to switch to teletherapy and telehealth, was that it opened the door to students who didn't have access previously, students maybe with a mobility challenge, or students whose mental health condition was so bad they couldn't get out of bed or get to the counseling center, the health center. I'm thinking about that student that's working all day and doesn't have time to leave work, go to campus, find a parking space, and then do their appointment and get back to work. I think there's opportunities that we never even understood existed. And they come with challenges, without a doubt. I don't think any of us would argue that that we'd prefer to see people in person when we can, but that's something that my organization is taking on as a advocacy issue, in advocating for those cross-state licensure issues and dropping them, particularly when you have an established relationship with a patient. A student that has to go home, for not just for a pandemic, for whatever reason, there could be a family emergency, that they can continue that work with that person they're seeing on campus if we can take care of that licensing barrier. Anything else on that topic? I will move on then to our next point. Next question is, what do you think the scope of care should be for counseling centers and the responsibility on institutions?
Yeah, that's a great question. I think it goes to a lot of the conversation that's also happening in the chat right now about how much do you invest in prevention versus response versus postvention. And as we know, with a public health approach, you really have to emphasize the prevention to be able to have the effective response and to be able to handle crisis or anything that may happen along the way. I think many college counseling centers are at this point of where they're analyzing and looking at their scope of care statements and what their responsibilities are. As we know that therapy works, right? And that could take a long time, but the need of our students may force us into more of a short-term service provision model. And so I think for every campus, there needs to be some level of true in-person related care on those campuses. And also we know that even at the most well-funded institution, the average counseling center utilization rate is 12%. At some campuses that are smaller or have more resources, that may be up to 25. Small schools may be closer to 30%. But we know again that even among students that go on to die by suicide, maybe only 20% of those were ever even seen in a counseling center. So again, if that helps you with this argument, is that you have to have prevention programs. We have to encourage integrated or at least coordinated related care on campus between physical health, mental health, substance use, and that we have to look at our model and see like what can we reasonably provide to our students to make sure that they're seen in a timely manner without a major waiting list where they're waiting and not being provided care.
I have done a mediocre job at best of moderating this panel because I've taken us right up into the last moment here and didn't leave a whole lot of time to wrap up. I want to thank our panelists, everything, the ideas that you've shared, the thoughts. I think and hope you've given the audience a lot of food for thought and maybe encourage them to think about something in a different way. Thanks to the audience for giving us some time this Wednesday afternoon, and again, appreciate the discussion I'm watching in the chat. And thanks to APLU for taking on this topic and pulling this group of people together to address it. We have a lot of work to do, but I'm optimistic and inspired when I get to talk with folks like our panelists today. So thank you and have a great rest of the day.
Thank you, Dr. Hoban, and thank you panelists as well for spending time with us this afternoon. For all of our guests, I hope you all see in the chat, it's coming through, sending all of your thanks. We appreciate your time and hope that you all will stick around for our next panel. Our next panel is dealing with highlighting university approaches to support mental health and well-being. And we're bringing in individuals who are embedded in different institutions who have different vantage points, either from faculty, staff, or generally from wellness within the institution. So we hope that you'll stick around. We are going to take a little bit of a break. And so we will be taking intermission and begin again at 3:45 Eastern time. So 1/4 to the hour. Thank you all again, and we'll see you soon.
Thank you.
Thanks. Take care, everyone.
All right, I think we're going to go ahead and get started with our second panel. Thank you all again for sticking around for our second panel. In our opening panel a few moments ago, we heard from individuals who were working in areas of mental health advocacy, in data and research and scholarship. And we were able to gather their insights, their thoughts, their forecasts around the state of mental health currently, and then their predictions on what it may look like in the coming years. Now, I would like to turn our attention more to some of our administrators who are embedded in the institution doing much of the much needed work now for mental health services for students, faculty, and staff. We've got a great panel selected here today, and to introduce our moderator, I will turn the floor over to my colleague, Abigail Robbins.
Thanks, Levi. Dr. Pamela Whitten serves as the president of Indiana University, Bloomington. As the 19th individual and the first woman to hold the role, President Whitten has emphasized three core missions. First, providing broad educational access for all students from Indiana and beyond. Two, pursuing world-class research, scholarship, and creative activity. And three, making meaningful contributions to improving the economic, social, civic, and cultural development of the world and the state of Indiana. During her first year in office, Whitten has accelerated the university's efforts to hire and retain diverse faculty and researchers, renewed its commitment to sustainability, and established an academic tuition and fees task force to simplify the process of setting undergraduate tuition and fees to ensure more transparency for students around tuition rates and finding ways to minimize overall costs of attendance for students. Before joining IU, Whitten held a variety of leadership roles, including serving as dean for 5 years at Michigan State University and as president of Kennesaw State University, and finally as an internationally recognized scholar in the field of telemedicine. We are elated to have President Whitten join us and add her voice to this much needed conversation. Please help me in welcoming our moderator for our second panel, President Whitten.
Great. Well, thank you. Thanks. And good afternoon from a sunny Indianapolis, Indiana. I'm delighted to be part of this timely and really important summit. And I really want to commend the APLU for hosting this afternoon's event to really highlight the rising concerns about the state of our students' mental health. You know, we all know that transitioning to adulthood, to college, to a new living situation with new people is certainly a challenge, and it's difficult. And doing this in the midst of a years-long pandemic can make it even more difficult as well. Given that nearly 20 million young people attend colleges and universities in the U.S., our institutions can play such an important potential role as safety nets to really protect young adult, mental health. College enrollment has actually increased by about 26% from 2000 to 2018. And it's actually expected to continue to rise to close to 37 million students by about 2029, 2030. And, moreover, the diversity of college students has grown over the past 25 years to include higher representation of students of color. And so there have been some very good trends that we've certainly seen in higher education in the past couple of decades. But a 2021 study showed that more than half of college students met the criteria for at least one psychiatric condition in the previous year. And according to the CDC, over the past 2 years, half of 18 to 24-year-olds report anxiety, half report a depressive disorder, and almost 2/3 in this age group report some sense of both. And so recent figures from the NIH corroborate these findings, with 56% of students reporting some sense of hopelessness and 45% reporting feeling so depressed sometimes that it was really difficult for them to function. And so we also know from surveys that these rates were higher among females and males, and students of color face these and really additional challenges associated with it, assessing care for mental health conditions. And so, in the face of these worrying and staggering figures and these really unprecedented times, we've really brought together a number of leading practitioners from universities across the country to discuss their view of mental health on college campuses. And I know that there are many of you participating that will have good input, but we have a superstar panel panelists, group of panelists today to speak with us. And so good afternoon, panelists. And I'd like to ask each of you to introduce yourselves briefly and describe your roles with your universities. And maybe we could start with Dr. Joanne Vogel from Arizona State University.
Hello, everyone. Good afternoon. I'm Joanne Vogel. I serve as the Vice President of Student Services at Arizona State, where currently we have 150,000 students, 77,000 of those who study with us across the Metro Phoenix area. I've been a mental health provider. I'm a licensed mental health counselor for 25 years, so it's really personal for me, the work that we're all doing. And it's a great afternoon for us to discuss some of the things that we're noticing as administrators and how we can continue to do the work in the role that many of you know student services plays in student success. What we want to see is undifferentiated outcomes for all of our students. And here at ASU, we focus on three things: building community, building skills, so teaching them, bolstering them, and then something we call healthfulness. So if I refer to that this afternoon, I did not say helpfulness, although that's a nice thing too. But the focus today really on how we build a healthful community for our students.
Great. Thank you, Dr. Vogel. Dr. Bernadette Melnick from Ohio State. Would you go next?
Yes. Hi, everyone. I left sunny Arizona, actually ASU, to come to Buckeye Nation about 11 years ago to assume a pioneering role as our university's first chief wellness officer. So my charge is to improve population health and well-being for faculty, staff, and students, and build a culture of sustainable health. We take a very comprehensive, multi-component, evidence-based quality improvement approach to health and well-being at Ohio State that I look forward to elaborating upon more. We've got to move from crisis intervention to prevention. And again, happy to talk about the successes we are seeing at Ohio State.
Very good, thank you. And finally, Dr. Mary Krogen from UC Davis.
Hi, welcome everyone. Mary Krogen, Provost and Executive Vice Chancellor here at University of California, Davis. For those who don't know, that's north of San Francisco and near the city and state capital of Sacramento. We have 66,000 people on campus, about 40,000 are students, and 26,000 between faculty and staff. My own background is as an epidemiologist, and we've been known throughout the nation and really across the world for our approach around COVID-19 mitigation, developed our own kind of very healthy bubble effect around UC Davis and our surrounding community and county with an integrated program of testing and required vaccination and masking and so forth. And through that approach of public health and wellness, I was asked to co-chair a working group for the whole University of California system on mitigating COVID-19 impacts on our faculty. So throughout the University of California faculty, what would it take to help them recover in terms of research and scholarly activities, teaching, and service? So I'll speak to students and staff to some degree, but my focus today will be more on activities for supporting mental health and getting through the pandemic for faculty.
Very good. It's wonderful to have all those perspectives. So let's jump into a couple of questions, and then we'll move to audience questions. So we have a chief academic officer, we have a chief wellness officer, and we have a vice president for student success represented on the panel today. And obviously each of these roles represents a different vantage point on these mental health issues. And so the first question would ask that you please discuss, how your work, though sometimes focused in a specific direction with a specific audience, as was just brought up to us, but how your work intersects with student, staff, and faculty mental health concerns. Maybe we'll ask Bernadette to jump in first.
Sure. When I first got to Ohio State, people were doing really great things. We had HR, your plan for health for faculty and staff. Student life was doing great things for students, but people were not totally aligned with the common vision, and there was no strategic plan for wellness. So one of the first things I did was pulled everybody together, any leader who had anything to do with health and wellness for faculty, staff, and students. We created a bold, exciting vision, strategic plan. We made the decision to take an evidence-based quality improvement approach. Because if we don't measure culture and outcomes, we cannot tailor interventions to where they're needed. I've long had a philosophy: in God we trust, but everybody else better bring data to the table. But seriously, measurement of the outcomes is so key. And faculty and staff wellness is critical to that culture and to student wellness too. So again, we take a comprehensive approach. We target top leaders, middle managers, faculty, the grassroots, policy, in order to make evidence-based changes that lead to good outcomes. That's just a quick snapshot of what we do.
Thank you. Mary, you have something to add?
I think recognizing between faculty, staff, and students that everyone has been in a challenging circumstance. Much of this even predated the pandemic, but the pandemic certainly exacerbated this. But kind of across the board, people have had fear and anxiety around their own health, the health of family members. They've had personal hardships in caring for children with K-12 schools closed, and subsequently trying to educate them at home or even just keep their internet bandwidth such that they could work and their children could do their educations. And then on top of that, for many people, having older parents where they were trying to, go grocery shopping for them or reduce their risks and exposures. So recognition that everyone was kind of at an 8 out of 10 already on stress and anxiety and concern for their well-being and well-being of family, friends, and loved ones kind of has heightened the likelihood or increased the risk, one might even say, for potentially not positive interactions. So where a student might be able to have a flexibility or accommodation provided in the past, a faculty member might be a little short in their conversation. So one of the things that we've worked really hard to do is to have a collective understanding that this is hard on everyone, that we all need to have more empathy and compassion for everyone in our community and take a step back, take a deep breath, think about it before you respond, and understand that you're having your issues and so is everyone else. So recognizing that the mental health issues, the need for access to care, the need for care, and how challenging that was at an institution level and also in the community, I think really helped to bring that sense across all three groups on campus.
Great. Joanne?
Yeah, I'll just add a little to what you've already heard is, and we heard it from the last panelists as well, is starting to realize that we are all committed to this, that we have universal responsibility to act on behalf of care and compassion and health for all. I think I believe my hopefulness says that we have turned the corner in some ways by talking openly, by being aware. And to everything you just heard is, people are a little raw and frayed. And so we teach a lot about what it is to communicate with compassion and how we've developed our community of care. And so we do know it's going to take all of us, because the student well-being, if I come at it from the angle that I work most around, how well our staff are, how well our faculty are absolutely going to have effect on that. And even if they can tell I'm not feeling well in this moment, but I'm going to tap out, or I'm going to tap someone else on the shoulder, or refer to the right next place so I can care for myself, that those are, that we honor those as good responses too, that not everybody has to be in the space to provide or they can provide as much as they can, is maybe said the better way, but get somebody to where they need to be if they cannot provide that for them.
Thank you. Mary, let's have you take on this next question, if you don't mind. So what hot button issues like compassion fatigue and general burnout, with those types of hot button terms and issues we hear about a lot, as we've all acknowledged, faculty and staff are facing similar mental health concerns, right? There's no one excluded from the dream right now that everyone's living. So, what advice or interventions would you give members of our audience today on how these concerns could or perhaps should be addressed?
So one of the things that we've tried to do through the 2 years that our campus was closed, essentially, and in this past year with being fully open and resuming full operations. One aspect of that was recognizing that there's compassion fatigue, after I just spoke about the need for that kind of compassion, flexibility, and empathy. And also that it takes people some time to adjust to being back in person. And we have a very broad reaching remote working option for staff who are able to do that, and a very high number have taken advantage. But then you have people who need to be here in person, and even for students, especially if they were incoming from 2 years in high school, studying fully remotely. And I know we may address this more later, but having some recognition that the students are coming in potentially with a lag in their social skills and some of their developmental skills around asking for help. And in fact, we're all a little rusty at it too, at providing some of those services. So again, that recognition that we're all trying to adjust has been helpful. And with the chancellor and I here on a daily basis during the closure, we did not work remotely, and we still don't. We have not taken advantage of that flexibility. But what we both found is as people came back, it took about 5 days for them to really get used to coming back to work. And by the end of the second week, there was this true sense of comfort and in fact, a joy at being back in person. And when we realized that was true for the staff and the faculty, we realized we needed to do that for our students as well. Give them time to adjust and give them the resources that they need. Start out small, not overwhelming, not huge lecture hall classes, not large assemblies or sporting events. Just give people time to really adjust to it was one aspect. The other really significant aspects that we did specifically for the faculty were the opportunity to submit, if they so chose when they came up for a merit or advancement, to write a COVID impact statement. How has COVID impacted their professional life and their productivity? Now, we made it optional. They do not need to get into any kind of personal details or circumstances, but a majority of our students on our campus have actually taken us up on this opportunity, either talking about, in some cases, they were actually able to get grants written or publications written that otherwise was a little more challenging if they spent more time in a field site or doing laboratory research. On the other hand, for most people, their research really suffered. Converting to remote instruction was very challenging for most people. And of course, what I already brought up with childcare responsibilities, elder care responsibilities, people really felt like things were coming at them from both aspects. So very importantly, those COVID impact statements have contributed to their files. They will be maintained there, and we will take those into consideration for the next 5 years, not just this year, not just in a short term, because it will take a while for people to recover and to not use up everyone else's time. One last important aspect with that is that we're doing all of our faculty evaluations in the University of California now for the next 5 years based on the terminology that's used commonly, which is achievement relative to opportunities. So what were the opportunities you had available to you during the pandemic, and what were your successes? So our clinical faculty at our 5 medical centers, you could pretty much kiss off their chance to do research because the patient care responsibilities were just completely overwhelming. So did they excel at patient care? Then you're tenured or you get the next level of advancement. So looking at what the opportunities were to that faculty member and what did they make of those opportunities, and therefore achievement relative to opportunities. And again, that'll be in place for the next 5 years. The ability to state what they went through and to be evaluated under reality of the circumstances they've gone through has significantly reduced the anxiety among our faculty. And I think it's also been empowering to them to know that we value the contributions they all made during the pandemic and beyond.
Very good. Well, Mary, after your comments, there's going to be hundreds of people that go back and quote. The provost at UC Davis said it takes 10 days. Just get people back in person for 10 days and they're joyful. So hopefully
they feel better.
They feel better, at least. That's good. Hopefully it'll be the case for all of us. Let's talk to Joanne and talk about students for just a minute, focus on students. And so, given the really staggering figures of students that we see in crisis, could you share with all of us some approaches that your institution has taken to address this issue specifically for students?
Definitely. And so I also know I will probably need to talk to staffing or ratios and the like, but I'm going to start with looking at the large part of the funnel. And so the things that we can scale, because many of us are at very large institutions, of course, and how are we going to reach the need? You heard from our last panelist that maybe only 12% of people are showing up in the counseling centers. And having been a wellness center director or a health and counseling director, getting up into student affairs, the answer used to be just send them to counseling. And we've all agreed, I think, that can't be the answer anymore. And so casting that net really wide in that primary prevention strategy way, that public health way, making sure that prevention stays front and center, and that we are looking at all the ways we can bolster those protective factors. And I'm going to add another P with protection and protective factors and health promotion and all those good ones is peers. And so one of the ways here that we know we have had to reach where we need to is to get our students involved. And that's through, it's fun when you're a sun devil, you get to use clever things like be a devil for devils, and then teach peers how to be in a place of support. And then those who are doing that particularly well, we have the next advancement layer for that peer group where they can become part of our Sun Devil support network. And that support network actually started as a focus for victims of sexual assault and sexual misconduct. And so we have figured out even how to scale up our peers into those who want to do some of the more basic peer-to-peer and listening type of skills, and then those who might become more interested, maybe some of our pre-health majors who want to get some advanced techniques and how to be leaders in their area. That's one approach. Another that we are really proud, and certainly I will open myself up to if people want to, after the webinar, be in touch with me, I can explain a little bit more about it, but we have invested in what I call more in the secondary prevention layer is something called Open Call, Open Chat. And that was actually branded through conversation with students because they thought it would get more people into either a text relationship, a counseling appointment through phone, so phone, text, chat. And that is a partnership with a company used to be known as Morneau Chappelle, is now LifeWorks, that was very prominent for some of you who may be more in the HR or business and finance world, did a lot of EAP work. And they've joined with us to brainstorm how it would be to have access 24/7, 365 to students in 9, I just saw the latest count, different languages. So we can even reach students who may want to seek support in their own language or their primary language. And that has been amazingly revealing in the last year of data that we've analyzed. It's actually upped our increase 17% of, if we look at the counselors that would usually have reach, it has now increased that capacity by 17%. Those who walk into our counseling centers are usually doing that. Our high volume day is Mondays, but funny enough, Open Call, Open Chat, where they're getting telecounseling chat, seems to have a peak on Wednesdays. 65% of the interventions are happening outside of business hours, so a reach we didn't have. So when we start to think about that funnel and who can serve peers, faculty, staff, students in this layer, then our more, I'd say, tailored intervention that's highly scalable. And then what we would all want to do, those of you who are public health experts and the like, saving our most specialized providers for those more complicated and complex situations. And so it has allowed us to do that. Now, we have roughly 50 providers in counseling services. I did tell you how large we are, so that don't take that. This is another one. Don't take my word back and tell everybody how many counselors you need now, because I'm going to challenge us and say, have we scaled up in all the other layers we've talked about? And where could you invest? It's not a small investment, but in something like an Open Call, Open Chat system that is providing the maximum net. And that was the part that was important to me. In all of the ways that students who may not walk into a counseling center, connect back with us through that platform. And so, we're tinkering. What's the right ratio and where we're going to put the resource and how many in each of those sort of layers or pieces of the funnel. But, I'm not saying we have it exactly right, but we have, I think, some promising practices, and we're definitely measuring it. Bernadette will be really happy to know that, to see what works.
Very good. Thank you. Well, let's turn to Bernadette. So Bernadette is, as the wellness director, if you will, at her institution, has, I'm sure, an interesting balance or challenge in her position, and that is the work that she wants to happen, but she has to work, if you will, directly with all the frontline people, right? So the people in the classrooms, our faculty, the leadership that serves our students, certainly, and our faculty and staff, our deans, our academic chiefs, through our provosts, those who run the international side of the institution, certainly those on the auxiliary side as well. So there's all those different line people that you have to figure out how to bring together and or come up with the special needs they might have, or the opportunity to have overarching ways to serve them as well. I know that can't be easy, Bernadette. So can you talk to us about how you have coordinated with all these different colleagues at your institution to create and or support these mental health initiatives for your students, your faculty, and your staff?
I first want to address Mary, because we kicked off a vitamin G campaign during COVID. Vitamin G for gratitude. It's one of the simplest evidence-based practices that if every faculty could remind their students at the start of their classes, let's all say one thing or person we're grateful for today. Same thing in the chat box. If you're Zooming, it truly helps. The coordination piece, Pamela, is super important because I talked about targeting top level folks. I sit on councils with leaders throughout the university. So I'm constantly there to remind people, to engage people. Chief wellness officers need to sit on high administrative places because that interaction with that top leadership layer is critical. But the other thing I want to mention, because it's so important, we can all have this phenomenal menu of wellness options for faculty, staff, and students. But if people won't engage in them, we're not going to really see the outcomes. So engagement, marketing, communication, but I'm going to be more radical than that. We have got to integrate evidence-based interventions that we know work into our curricula, our academic programs. As long as these things are optional, students, faculty, and staff, they're too busy with all their core requirements. We are doing this more at Ohio State. Several of our colleges now require our wellness onboarding program. They require our evidence-based cognitive behavior skills building program, so we can ensure we're equipping our students with life skills that they'll need forever.
Very good, thank you. Thank you. So this last question we'll ask before we go to audience questions, we'll give everybody a chance to briefly weigh in. And like our panelists, I come from a large university. Indiana University now has 91,000 students. And we took this opportunity of, kind of the crisis of the mental health crisis to tear up our strategic plan for behavioral health, mental health services, and have been pretty ambitious in creating something new that we're finalizing, hoping to launch next year. And of course, tied to that is identifying the resources that are necessary to do all the things that we need to do. So, obviously, some of them being very scarce resources, as we all know these days. So I would ask each of our panelists to recommend to our colleagues at other institutions that are with us today in this call, what resources that you think are a must-have when they consider designing their own mental health overall program and or interventions. And please be as specific as you're comfortable being. Joanne, you want to go first?
So must-have resources. I'm going to do a little shout out to a chief wellness officer or a chief well-being officer. I do think that has been, we have brought on a new one in the last year who is really looking at the ways we can faculty, staff, and student coordinate. And so I think whoever is in charge of doing that or can step forward and make sure that we are all connected, I think has been really, really essential. Another way that we've connected and another resource I think is what I'll call sort of bridging resources, whether those are trainings in listening for people who are interested. I know I've mentioned a little bit of that before, but I can't overemphasize how important even some of the basic skills are. We're talking a lot in our environment about getting back to basics, because I do feel like we have forgotten some of those. Mary, you mentioned earlier some of the relearning. I think it's even that, how to be present. Think about what the digital space has done to us, how to listen to each other. But the other thing where I found some interesting, and it's not a high dollar resource, isn't that a relief, is in some of our support circles. And so back to some of those of us who are therapists by training or have been in the helping fields for a long time, this is a common thing to see support groups pop up, whether it's a cancer support group or a grief support group. And I think one thing that's really resonated, so I think invest some resource, time, and energy into this, is support circles, where we have somebody who says, I'll host it in the multicultural center, and we're going to invite a faculty member who may not ordinarily be talking a lot in the emotional space to co-lead it with maybe one of our counselors, but it doesn't even have to be that, because remember, support groups didn't necessarily need people who were licensed or credentialed in a particular way. It was people joining together and supporting each other. And so as I throw out some of the resource ideas, I do caution, and sometimes I probably just look like the administrator who's looking at the bottom line financial dollar, but not all of these things do require an intensive infusion of money. Some do, so I would not pretend otherwise. But this is where I think getting the right group together to just really, in the way President Whitten, you said, is sometimes you just have to rip up the plan and recreate a new one in the context and the culture that we're in now.
Thank you. Bernadette?
Joanne, I'd like to follow up with your CWO comment. I'm in a network now of about 35 CWOs. But here's the challenge. A lot of people will call me as they're getting started in their CWO role, and I will ask them, what resources were you given for your role? I will tell you, 8 out of 10 people I talk to say, well, I have 0.5 FTE time. That's it. And I think places are checking a box. Yes, I've got a CWO, but they're not being provided with the resources they need to be successful. And the best thing that I advise people that are looking at this role is to make the argument with the evidence that investing in wellness has a $2 to $4 return on investment. At Ohio State, we calculate that every other year. The last time we calculated, we're getting $2 back for every dollar we invest. It pays for itself. And then if you go beyond just ROI to value of investment, if you invest in this, you're going to see less absenteeism, less presenteeism. Your students are going to perform better academically. So if you can show university presidents and provosts that kind of data, resources will come with it.
Very good, thank you. Mary?
So a couple things. I'll turn to the faculty a little more than the students, but I would like to echo what both Joanne and Bernadette have said about peer counseling. I was a peer counselor when I was an undergraduate, actually here at UC Davis. I got to return home here as provost. But I think those kind of peer counseling and support mechanisms work at the staff and faculty levels as well. And we forget about that, quite honestly, whether it's It is things like parent support groups or looking at different aspects of your work. I know I had a peer mentor throughout my entire time as a faculty member. We met together once a month for lunch and had to produce something for each other to see, a grant or a paper. So I agree with you, and I think it occurs at all levels. In terms of some very specific things that I'll direct it more towards other provosts as you ask the question. One is to ensure that your campus really does have outdoor opportunities. There's the benefits of exercise for people walking. There's the chance to get outside, to be in the sun. I know for some areas, the weather might be either end of the spectrum to make that a little more challenging. But during the pandemic, our arboretum on our campus, which is several miles long and a pretty large outdoor beautiful area, it was a haven for people to be able to come, to be able to be together and yet be outdoors. And it's continued. It's always been that for decades, but it's continued, and probably its significance has risen even more. So quite honestly, from a mental health standpoint, from a physical health standpoint, I think outdoor opportunities and activities are really important. Also, we do have wellness officers on campus, but we have a wellness coalition of different groups that come together. And again, some of those are peer outreach. We have people who are certified yoga instructors, but they offer yoga for free in a remote environment for anyone who wants to take that, say 3 mornings a week. And so they're doing that as just a gift back to their colleagues. I think we have a faculty member whose job is to help other faculty when they become parents. And that might be a newborn or adopted child or a foster child or stepchildren who are older. But this person, as a distinguished professor, her job is to reach out to those parents and ensure that they have the support mechanisms they need. They know about policies and flexibilities, stop the clock rules, all those kinds of things, and make sure people are well informed. And then beyond that, I think the research recovery funding that provosts can provide, and that is to faculty and very importantly to graduate students and postdocs. And we did that throughout the pandemic, but it's continued. And one of the things we also did that had a breadth of assistance in decreasing people's anxiety and stress was to make more TAs available to our faculty and more graduate student researchers. So that enabled them to make greater progress, and it enabled our graduate students to ensure that they were funded knowing that their own research was going to prolong their time to degree. So again, I think the mental health, you can approach it from multiple perspectives of actual service provision, but also from the other side, as has been mentioned, from prevention. And that multi-pronged approach will get us all further.
Very good. Very good. Let's jump into some audience questions. You all are welcome to either talk about what you're doing or your ideas, even if there aren't things you're necessarily implementing on your own campuses first. And so the first question is what can we do to orient people toward prevention and away from the focus on, response services such as counseling or always emergency urgent responses? And so the questioner says, when we discuss mental health on our campus, everyone is all in, but they only want to hire more counselors, which is part of the solution, of course. And so how can we get broader buy-in for prevention efforts and more of a healthy public health approach? Who'd like to jump in first?
I will. We spend more money on healthcare than any Western world country, but we rank in the bottom of population health outcomes. Partly that's because we only invest 8% of our healthcare spending in wellness and prevention. One of the reasons we have trouble shifting this paradigm is because people want to see immediate results or outcomes. And it really does take time, but it is an absolute necessity. We'll always need great counselors for crisis care. But unless we start shifting this paradigm toward prevention, integrating evidence-based things that we know work, we still have a 15-year time gap between the generation of evidence and its implementation in real-world practice. We've got to de-implement what doesn't work, what's not evidence-based, and then we'd have the resources to focus more on prevention.
Thank you. Who else?
I'll add in, when I got to ASU, there was a campaign that caught my attention and seems to resonate well with our students, which it could go across faculty, staff, and students. And the tagline of that is build your best you. And I think my initial reaction was, well, wait, I want to build our best us. I had this moment of like, I think it should be more collective in its responsibility. But I've actually come a bit around to there's room for both of those things. And so when is it appropriate to build your best you, where you're setting your own, learning about, and so how are we getting, Bernadette, you made a great point earlier, we can get all this into the space, but if people don't actually use it, do it, implement it, we're still going to be back where we have been. But what I liked is it met, and we have, of course, the range of ages of students in our backyard, but some of the ones we were focusing on here were those who are maybe younger adult, developing those skills. And there is a focus on self that might look different than it might in a different part of the lifespan. And so bringing to them, what is that part that you're going to focus on to build? Is it those healthy practices? Is it working out more? Is it, I've tried all these things and I can't figure out what the obstacle is, and I'm going to figure out where to go to figure that out. And at the same time, I do think there's room for, although I have not had them rebrand this, to build our best us, but if we're all building our best use, and then we're looking out for those who are struggling and might be stuck in the journey of doing that, then we're doing all the right things to build our best us. And so, you know, I know these things kind of sound maybe a little cheesy or a little bit like, is that going to die on the vine? But something that grabs that attention, and then we track back all of our health initiatives and health focus, at least in the students, to that. How can they be well, live well? And so some of these taglines that we shift and change up time and time again, just to refresh, I think that's another thing too. Sometimes this can become noise in the space, and we have to be really careful that we are refreshing, if not outright rebranding at times, to just capture attention again.
Mary?
I'm going to defer to both of them, even with my own public health background. I think they've both made excellent cases for the comprehensive nature that you need to use as an approach here.
Very good, very good. Well, we'll ask you to go first in our next question, and that is it's a question near and dear to me as someone who was a telehealth, telemedicine researcher for many years, decades ago. You know, we those of us in the field joke it only took a pandemic for it to become ubiquitous, and so the question for you all is, how have your campuses used or not used telehealth services, and you know, were there upticks in the use of telehealth? And if so, has that maintained or has it changed now that people are coming more back in person?
So if you do really want me to go first, and you would know this as somebody who did research in the field. So Tom Nesbitt in UC Davis is one of the founders of the whole concept of telehealth. So quite honestly, none of us would wish a pandemic upon anyone, but it did give an amazing natural history experiment to prove the value. And not only has it been a value in our patient care activities, in clinical provision of care, but also in things like mental health outreach and services, and quite honestly, student advising. And I think one of the important aspects has not just been access, it's much easier to get on Zoom or your cell phone to be able to speak with a provider. But for many people, it's meant they didn't have to find a babysitter. They didn't have to arrange transportation. All those things that we've known for decades were advantages to it. But importantly, it's also given providers some insight on other circumstances. Sometimes you're actually looking into a person's home, a student's home, and seeing that they're under some challenging conditions in the background. Unfortunately, that's also led some of our students to never want to turn their cameras on. And I think there's a balancing act there, but it has provided an opportunity to maybe broach that subject. Also, our students and in fact, our faculty and staff have talked about not just the convenience, but that they feel more comfortable sitting in their own living room, sitting in their own bedroom, having these conversations, and they find they actually disclose more than they did under a clinical setting and circumstance where there might be fear of other people overhearing the conversation. And it just felt like a more sterile environment in a clinical setting. So I'm personally always been a fan and big believer. I think there's also obviously the need for in-person care under different circumstances. But I think in particular, this can be much greater value in intake, much greater value in circumstances where access is problematic and where you can, unfortunately, possibly maximize the usefulness and hours and time of providers at times.
Thank you. Joanna, Bernadette, any increase in your institutions?
I'd like to mention a couple of things. We've also moved to a model to embed counselors in our colleges, because that really cuts out those longer wait times and easy access. The other thing I want to mention, with the rise in suicide, the American Foundation for Suicide Prevention has an interactive screening tool for suicide risk. You send it out, it's encrypted. There's a counselor on the other end, but they don't know who they're communicating with, but they get the people help. And we are starting to roll this out across our entire university. It does not cost much, and it identifies people at really high risk for suicide and gets them help.
Very good. Thank you. We just have a few minutes. Let me ask you all just one last question. And this is a hard question. So you all might act like your mics don't work or something when you get this question. And we're all representing public universities, and very, very proud of that. And we all know that, of course, we have finite resources and challenges down the avenue in terms of those resources in the future. So given this increasing need for behavioral health, mental health services, and the increasing expectation that those services will be provided from the university, not just for students anymore, but beyond, how are your institutions paying for this or planning to pay for this in the future? Joanne, you want to try that first?
Yeah.
Sure, I can. So we're getting really creative. Of course, we're looking at all the ways. And Mary, you mentioned one I'm going to highlight from the last question is the role for us of some of the telemedicine and has been really helpful because we have 4 health and counseling clinics separate across our 4 locations here in the Valley. And it has become helpful when we think about just conserving resources as one way to do this is being able to flex providers where it might be slow one place, but there's a backlog or a waiting, there are people waiting in the waiting room who can now do telemedicine somewhere with the provider at another location. I mean, we're getting super creative. Another thing we're looking at is, we heard earlier about HERF funding, of course, or the funding there. And we're looking at grants very closely, because there is a lot of money out there to be had as supports our efforts and initiatives. I also think it's a great way to conceptualize what that will be that you're going to implement. And then almost every time I've ever written a grant is on the back end, how are you going to measure it and how are you going to sustain it if the money were to go away in the future? And so I think that's a great thought activity, even at times if something didn't get funded. And then the other place too, and I know this is probably not a popular route, or it's a little hard at times, but I have great hope in our students as well, that as we have talked to them about the importance of expanding services or adding services, they're coming to the table with us to talk about increasing their student fee around health and counseling. And is that another way that we could add in and expand some services for them? Now, they are sharp students, as you all know, and they want to know how we're going to demonstrate that we've used those funds appropriately and effectively. And I'm up for that challenge. So that's another route I would add in.
I can add, I will be clear and transparent that I'm advantaged in this situation, that as provost, I have control over the budget. And at UC Davis, that's 6.2 billion with a B. I allocated, I guess now it's almost 18 months ago, I allocated an additional $3 million just to undergraduate mental health services. And as Bernadette said, we already had a counselor in our graduate studies division full-time. We had counselors available in several other colleges and schools, but this was the centralized service available. I'm saying it undergraduates because that's where our larger numbers are, but it's available to all of our students. The trick, quite honestly, though, is as good as that was, that I allocated that from central sources, we have had an incredibly challenging time hiring. And you're all nodding your heads yes, and I've heard from others that this is common. So really what we've had to do is get more creative. We've turned to our psychiatry department in our medical center to provide services. We've done community partnerships as well. But very importantly, we started to partner with our own trainees. So we have a psychiatric nurse program, a PhD psychiatric nurse program. Now their students will be coming over and do their placements with our student mental health services and counseling, for example. So what could we do to maximize and have a win-win for our trainees and increase the number of our service providers? But we still need more people, even with telemedicine, even with a recognition that this needs to be comprehensive and not just focused on crisis, but also prevention. We need more people there.
Mary,
Yes.
it's so good to hear you say that, because we leverage our health sciences colleges to really do programming across the university. And I think a lot of universities don't leverage their colleges of nursing, medicine, public health that could really be a low cost, feasible strategy and give students great experience too, although we have to follow FERPA, HIPAA, all of that.
Right.
Well, thank you. I think the catchphrase for all of us across all of our institutions in the last year has been, oh my goodness, we can't hire our way out of this one, right? And so we're all having to be so much more creative. So, well, as we come to the end of our time, let me send my thanks to Doctors Vogel, Melnick, and Krogen. You guys were just terrific. Thank you so much for sharing your thoughts and your insights on this issue that's so timely, and I know it's so important to all of us. And with that, let me turn the mic back over to our organizers.
And thank you, Pamela.
Thank you.
All right. Thank you all again, moderators and panelists, Dr. Witten, everyone for participating in our second panel and sharing your perspectives, tools, insights, everything that comes along with working in this critical issue now. As we all know, this is going to be a fairly persistent issue for us over the next couple of years and perhaps beyond. So we thank you again for sharing your expertise. And look to maybe inviting you in the future as we begin to tackle this more in the coming years as this issue will stick around. For our guests, I hope that you will also join me in thanking our panelists and moderator for our second panel, and then for all of our speakers who have stuck around. We really appreciate the time, dedication, and working with us at the APLU and all of our partners at our research universities. That brings us to the end of our scheduled events. As my colleagues have, I think, maybe posted in the chat, we will be taking the recording of this and cleaning, sharing it with our panelists, and then posting it to our website. And we'll make sure that a message goes out to everyone when the recording is available for folks. Thank you again for attending, and we look forward to seeing you at our next event soon.